Good evening and good morning, and thanks for the organizers for this wonderful opportunity to combine with my friend Dr. Balaji, who is actually instrumental in making this PowerPoint presentation. It's just a conversation between us, and obviously we know diabetes is associated with a lot of infections, and especially urogenital infections are very common, and is one of the important reasons for hospitalization. And we know there are certain conditions like emphysematous pyelonephritis, which are nearly pathognomonic of diabetes, and it involves a lot of cost also on the family when someone gets urogenital infection, especially complicated ones, and get admitted. So in that context, in our daily practice, this is an important topic. And many a times patients come with a mass child check report with a lot of abnormalities, highlighted biochemical values. And urine analysis is one of the important feature of MHC. And many a times we are bombarded with abnormal reports, and we have our own dilemma of how to handle this. So we'll be discussing all this through this presentation, case vignette form, and there is no conflict of interest. The references are taken from reputed sources like UpToDate, ITSA, as well as APA textbook of medicine. So, Balaji. Yeah.
So what do you think are the common risk factors for urogenital infection? There is a common understanding that urogenital infections are more in diabetes. So what do you think are the causes, common causes?
See, obviously, we know from published data that even people who are having known diabetes remain uncontrolled. A significant proportion of our patients, even attending diabetology endocrinology clinics, they have uncontrolled diabetes. That becomes a big problem because glucose in urine becomes a good milieu for bacteria to grow. It's a nutrient for the bacteria. So poorly controlled diabetes is one of the biggest risk factors for UTI. And all diabetic patients, they do have immune dysfunction. And in patients with diabetes, there is more risk of biofilm formation. For example, if they are catheterized, there is a biofilm formation which protects the bacteria against penetration of the antibiotics. And more bacterial adherence to urinary tract also happens in diabetic people. And long-standing diabetic people do have autonomic neuropathy, they have bladder dysfunction. Even after voiding, they have a significant amount of residual urine that becomes again a good culture medium for the bacteria to grow. And also, we use a lot of glyphosins now with a lot of evidence for them to use. Obviously, we will have a discussion about glyphosine and urogenital infections at the end of this presentation.
Most patients with 80 plus diabetes, they will have autonomic bladder. The classical definition of autonomic bladder is painless distension of bladder with more than 400 ml of urine. That is an independent risk factor. In those patients, be careful about starting glyphosins. Also, prostate, BPH with significant post-void urine, by definition more than 150 ml. That also can be an independent risk factor. Be careful before starting glyphosins for those patients because it will be an add-on. Next slide.
And Dr. Balaji, when it comes to doing lab tests, the basic one is the urine analysis. So do we have any recommendation about how to collect the sample,
Yes.
which sample to be used, whether it should be always an early morning sample or a random sample can be used, or is there any other way of taking the urine sample like suprapubic aspiration and so on?
Yes, next slide. See, the ideal theoretical, the textbook way of collecting the urine sample is clean catch midstream first micturition sample, which is almost always impossible to do in a daily practice because the patient has to be at lab at 5 o'clock. He has to come with full bladder and give a sample. If you allow him to collect in his home, sterility is not guaranteed. So that is a very theoretical thing, not always practical. But theoretically, the first sample reflects your bladder colonization very well because at least 4 hours of colonization in the bladder is needed. Practically, that's not possible. So the next best thing is to go for a random sampling. Next slide. If you see random sampling, it's a midstream urine with or without cleaning the urethral meatus. Whenever somebody walks into your OP at any time, even during evening time, you can take a sample as long as you make sure the vaginal or urethral secretions don't contaminate. So they have to spread the labia or pull the foreskin before collecting. So it's a very practical way of collecting a urine. Random sample is acceptable, sir.
Yeah. Then, then comes the question like, what are the urine tests to be ordered? So we have got a lot of tests possible. Like for example, you can order a urine microscopy. Sometimes we call it as a urine routine, but the correct technical term is microscopy, because microscopy is the gold standard where they can actually see the or measure the number of red cells or white cells, but you need a technician to do that. And urine dipstick and urine culture. Would you do all the tests for your patients, or would you selectively do it?
Yes. So if you see, always ask together in the context of UTI. I'm talking in the context of UTI, not in the context of proteinuria. Go for urine microscopy and culture together. But microscopy may take 24 hours to come, the report. It has to go to the lab, some technician has to read manually, get you a printed report. It may take up to a day. But go for dipstick and culture together. The point I want to tell, don't ask for culture alone. That's the main point you need to know. Always it should accompany either microscopy or dipstick. For convenience purpose, dipstick and urine culture should go together. That's easy. Randomly you can do. And quickly you will get the dipstick reports. The point is, don't ask cultures alone. It's not a standalone test. It has to go along with this. And sir, if you see a vignette like this, it's a very common patient who runs into our OP, walks into our OP, a long-standing diabetic, a perimenopausal woman, 25 pus cells in eye power field. Sudden, you get a report. So this is definition of pyuria. So how do you react when you see this?
See, first thing we have to check whether the patient has got any symptoms, because urogenital infections we never treat unless it is accompanied with symptoms. So this is a lab report. The patient, if the patient is hale and healthy, 25 pus cells doesn't mean anything unless she is pregnant. There are certain exceptions which we will discuss later. So pyuria is defined as any number of pus cells, say leukocytes more than 10 per high power field. Manual counting of leukocytes can be done. The urine has to be centrifuged, or they can use a technology called hemocytometry. Lack of pyuria almost always suggests against UTI. So in UTI, there will be pyuria. But the absence of pyuria, it has got a high negative predictive value. So that means if there is no pus cells, then it almost rules out. Pyuria is not a surrogate marker of bacteriuria. Bacteria without pyuria is probably colonization. So there can be bacteria in urine, but pus cells may be absent. Then it could be due to colonization, it is not true infection. So that is very important. Pyuria, along with bacteria, along with symptoms. If there are no symptoms, don't treat. If there is pyuria coupled with bacteria, then you have to ask for cultures, especially if it's a complicated UTI. In uncomplicated UTI, even without culture, you can treat.
Yes.
With that, so
all three, the take home is for an MHC, when you see sudden walk-in patient, otherwise very well, all right. Only when you see all three, pyuria, bacteriuria, symptoms, all should be there. Then only you should go for cultures. Otherwise, you will be unnecessarily repeating the cultures, which has no value. There are some exceptions we will discuss. So when this patient has excess pus cells, but cultures are negative, inadvertently somebody has asked for a culture, or you see a culture report, patient walks into your OP. So how are you going to react? 25 pus cells, but urine culture is negative. So this is kind of a culture negative pyuria, or we can call it a sterile pyuria. How are you going to react?
Now, first thing we have to get the history, whether the patient got exposed to antibiotic by the previous physician. So probably she is already a treated case of UTI. So previous history of antimicrobial history is very important, and it could be due to vaginal leukocytes and secretions. And any stone in the urinary tract, nephrolithiasis, can cause sterile pyuria. Infection, it is inflammation. And uroepithelial malignancy, Atypical organisms like chlamydia, tuberculosis, ureaplasma, ureolyticum can cause sterile pyorrhea. One of the important causes of sterile pyorrhea in India is tuberculosis of the urogenital tract. And majority of the times these people get diagnosed when they go for the infertility workup, especially women going to IVF centers having an infertility workup, they get diagnosed with tuberculosis of urinary tract.
The urogenital TB is quite common in a poorly controlled diabetic in our country. Persistent pyorrhea, vague lower abdominal pain. They may not complain of dysuria. Vague lower abdominal pain, persistent pyorrhea, cultures negative. This is the triad of urogenital TB. Keep this in mind. Have a low threshold to quickly do it. So, how are you going to put urine dipsticks into use? Most of us have moved to dipsticks, and I think most clinicians don't do urine microscopy because this looks quite convenient and best use in the context of urinary tract infections. Next slide. So, if you see a classical dipstick will give you a variety of reports, not just glucose, it will also give ketone, it will also give protein, microalbuminuria, leukocyte esterase, nitrate, multiple things you get in one dipstick. This can be put in best use as long as we understand the positive and negative predictive value of each test. Next slide, sir. So, if you see, this is a classical, the interpretation you get. Next slide, sir. So, dipsticks easy and cheap. In the context of UTI, there are two dipstick positivity I am interested in. Leukocyte esterase and nitrate. Most important, do not do dipsticks if there are no symptoms of UTI in the context of UTI. You want to do it for microalbumin, that is different. For UTI, if the patient denies symptoms, don't unnecessarily do a dipstick. It will confuse. It is like culture. So, it will confuse you. It will give unnecessary information. Too much information overload is also a problem. So, don't do unless patient has a urinary symptoms. Next slide. So, if you see one thing, the leukocyte esterase corresponds to pyuria. More than 10 leukocytes per hyperfill, it corresponds to leukocyte esterase. If you see, the sensitivity and specificity is better than pyuria. For pyuria, to measure pyuria, you need a technician, you need a microscope, you have to create a slide, you have to put under the microscope and somebody has to see, generate a report, type and give to you. It may take time, labor intensive, but you just do a dipstick, leukocyte esterase positive is corresponds to pyuria, but it has its own sensitivity and specificity. If you see nitrite, next slide, sir. If you see nitrite, that corresponds to bacteriuria. So you have a surrogate for bacteriuria and pyuria. So, if you see nitrate, there are false positive and negative. It works very well for E. coli, Proteus and Klebsiella, which are the common urogenital organisms. That is enough for me because these three are going to be the reasons for 95% of the UTI, right? 95% of the UTI. So, if I can rule out these infections with the nitrate test, that helps me as a clinician. But make sure that there are other organisms which can be missed by a nitrate test. So, keep this in mind. When the patient doesn't improve in spite of being a negative dipstick, keep these organisms in mind. And at least 4 hours incubation in the bladder is needed, okay, for this. So, how am I going to use this? Please, next slide, sir. I will use together. So, when both nitrite and leukocyte esterase are positive, if you see the positive predictive and negative predictive value significantly increases. So, when both the dipstick are positive, I am quite confident that I am dealing with an UTI. I will ask for a culture, urine culture, and then start an empirical antibiotic. Meanwhile, the culture reports may come 3 days later. Meanwhile, an empirical antibiotic can be started. So, this is a point I need to tell.
Yeah. Now, the next important question is when to ask for urine culture for my patient. So, the answer is obviously we have to do urine culture only when the patient has got symptoms. So, when the patient presents with either upper urinary tract or lower urinary tract symptoms, so the common symptoms are dysuria, frequency, urgency, coupled with suprapubic pain or costovertebral pain, or the patient is running high temperature, spiking fever, or the patient is experiencing new onset delirium or hypotension. All those situations, we have to ask for urine culture. And it need to be always done along with urine microscopy, and it need to be done before always starting the empirical antibiotic therapy. So, first send the sample, appropriate sample for urine culture, then only start some empirical antibiotic if needed. So when there are no urinary tract symptoms, don't ask for cultures. It's not going to be useful. But there are certain exceptions. So even if the patient has got no symptoms of UTI, especially when you see a patient in early pregnancy, because when in early pregnancy, if you are going to miss asymptomatic bacteriuria, it can lead to maternal pyelonephritis, and it can lead to an early delivery and low birth weight babies. The other conditions where you have to do urine culture is all immunosuppressed states or post-renal transplant within a month of it, because they are on high dose of immunosuppressants. The risk for UTI is very high. Within a month of renal transplant, we have to ask for urine culture.
These are the 3 standard indications where you can ask for cultures even without symptoms. So please keep this in mind. Next slide, sir. So 70 senior citizen, long-standing diabetic, CAD, Parkinson's, bedridden, indwelling Foley's, either in the hospital or a hospice. So how frequently should I do urine cultures? How to collect urine samples? Next slide, sir. So if you see, ask for sample, the same rules apply. Any catheterized patient, there will be bacteriuria, no doubt. That is their birthright. So don't ask for cultures unless COTY symptoms are there. Patient should have a fever, low backache, delirium, hematuria, cloudy urine. Any one should be there. Delirium without fever, always keep this infection in mind. Infection is a common cause of delirium in geriatric population, even without fever. Okay, so you can ask for cultures as a part of delirium workup in geriatrics, not for any other patient. Next slide. So the most important point here is we need to understand the anatomy and the tubings. If you see Foley's catheter bulb, you have a connecting tube and it goes to the drainage bag. And where to take the sample, that's the most important, because I am sure as clinicians you will be handling a lot of geriatric patients. They may even walk into your OP with the urinary bag by their side, or you may treat them in-house with your nurses or ward boys. Next slide. So if you see, the ideal way is to clamp distal to the collection port. Every Foley's catheter will have a collection port. So clamp distant to the collection port, clean with the betadine gauze, and then connect your syringe to the collection port and collect the urine. This is the best way to collect urine sample as long as the patient has symptoms of COTY. Otherwise, don't even think of taking a culture in this patient. Okay, it will grow something. It will grow. Okay. So how to interpret positive urine culture reports? Next slide, sir. See, positive urine culture, we are trained to see the numbers. More than 10 power 5 colony forming unit per ml. Though bladder is a sterile area, the conduit through which urine comes, either vagina or penis or the external urethral meatus, they are not sterile. So you will expect bacteria in the culture. That's why they have come out with the quantitative number here. More than 10 power 5 only it has a value. But there are some exceptions where males, they have no business to get an UTI unless they have a stone or stent in place. Females often get UTI because of menstrual cycles, contamination and all that. But if they have, males have, you have to go for a lower numbers. Previous history of antimicrobials, go for a lower numbers. Symptomatic females with pyruvia, you will commonly see this in the OP. Very severe symptoms, always complaining of abdomen pain, dysuria. Even 10 power 2, maybe you can treat. Otherwise, be careful with the numbers. Always look at the quantitative numbers and treat. Next slide, sir. So, asymptomatic bacteria is another controversial entity now, but we have a clear evidence now. Routine MHC, that is a problem. Routine mastral check, they come out with the culture bacteriuria, but the patient will not have symptoms. So, how are you going to approach this? So, asymptomatic bacteriuria by definition is bacteria in the urine, no symptoms, with or without pyuria. This is very common in the mastral check. Next slide, sir. If you see, never screen for asymptomatic bacteria, don't even ask for culture in the general non-pregnant population, including diabetics. As we are all basically diabetologists, I am telling you, don't screen for asymptomatic bacteria even in diabetic patients. That's going to be extra, confusion for you and extra expenditure for the patient. Don't do that. We cannot do anything with that report, okay? Because more than 7,000 patients included in a meta-analysis of 50 studies has clearly shown no benefit of routine screening of asymptomatic bacteriuria except in situations like this. Pregnant patients Pregnancy, asymptomatic bacteriuria has a clear link with premature birth and pyelonephritis. So at the first trimester, the end of the first trimester, you have to ask for a urine culture. If it is positive, treat with 4 to 7 days of treatment, and you have to ask for a repeat culture to prove that it is negative. And that holds true for endourological procedures where mucosal bleeding or breach is expected. There you can treat. Give 1 or 2 doses close to the stenting alone, not prolonged course, just 1 or 2 doses. Okay. And renal transplant, maybe within 1 to 2 months, there are some data. And you have to prove with the repeat culture. In general UTI, any UTI community, walk into the OP. You diagnose UTI, you treat UTI, you never ask for a repeat urine culture. That is not needed actually. Diagnose UTI, treat UTI, send them if they become all right. We don't ask for a repeat culture. But in these situations, you have to ask for a repeat culture after course of antibiotics as per the guidelines. Next slide, sir. So, the point, diabetes, don't screen for asymptomatic bacteriuria. Postmenopausal, geriatric, institutionalized patient, indwelling catheters, nowhere data is there to show that routine screening for bacteriuria is going to be helpful. Don't do that. Next slide, sir. So, how to decode urine culture reports? Next slide. So, you will always see a report like this on multiple numbers, resistant, sensitive, more than, less than, more than, resistant. So, so I am going to give you a simple approach to how to decode a culture from a physician's perspective. Okay, next slide. If you see decoding the urine culture, look at what organism you are dealing with. I am talking of urine culture. How to identify the organism which is already given. And note the colony count, as I already mentioned, 10 power 5 or maybe 10 power 2 in a selected population. Note the minimum inhibitory concentration, note the breaking point, suitable antibiotic, and site of it is a urinary tract. So, MIC and breaking point are very, very important in choosing the right antibiotic. Next slide, sir.
To put it simply,
Yeah.
like you can ask 3 questions. What is the organism? How much is the organism? And what works against that organism? So that's what we need to answer in this call.
For example, you may have a very sick patient with a bug which shows teicoplanin as sensitive. You cannot give teicoplanin. It will not go into the urinary tract. Vancomycin, it will not go into the urinary tract. You have to ask yourself, the antibiotic you are choosing is going into the urinary tract. That's the most important question, because they do the culture in the plate or in the machine, but the organism is in the urinary tract. It has to go into the urine. So keep this in mind. Conventionally, at least 2 decades before, they were using Kirby-Boyer disc diffusion method to tell you the MIC. They'll keep the antibiotic in the middle and there will be a zone of inhibition. Based on this area, zone of inhibition, they will tell you whether the antibiotic will work or not. It is a pictorial representation. They will tell you it will take 3 days to work for you to get the report. Now, we have moved to Vitek systems. All the labs, 100% of the labs have moved to the Vitek system. It's a quantitative antibiotic susceptibility testing system. It will take just maybe 1 or 2 hours for you to get the report, where the MIC and breakpoints will be printed and given to you. The life has been made simple for us, for clinicians. And what is MIC, what is breaking point? The next slide, sir. If you see MIC, by definition, it is a minimal lowest concentration of antibiotic that helps the bacteria. The next point is the best take-home message I can give you. It will tell you what class of antibiotic you can choose. It will help you to choose whether I am going to give a cephalosporins, or whether I am going to give a quinolone, or whether I am going to give a macrolide. That is the information you will get. It will not tell you which antibiotic. Okay? You cannot say lowest MIC, I will choose this antibiotic. That's not the way it works. Most important point, one antibiotic's MIC should not be compared with another antibiotic's MIC directly. It has to be correlated with the breaking point. I will show you an example for this. See, MIC is reported as 3. Any culture report will tell you sensitive, intermediate and resistant. Sensitive means organism is inhibited by the serum concentration of the drug that is achieved during the usual dose. Usual dose, that's a point. Sometimes some organisms will be inhibited by maximum recommended dose. The maximum recommended dose for meropenem, for example, is 2 gram 8th hourly. But the usual therapeutic dose is 1 gram 8th. How many minutes I have? over. So I'll quickly rush. Last 2-3 slides. These are the most important slides. So if you give 1 gram 8th hourly, it works means it is sensitive. On the other hand, if you have to give 2 gram 8th hourly means it is intermediate. So don't go for a I. Unless you have no other antibiotic choice, don't choose an antibiotic with I recorded. It will not work because you are going to use a conventional dose. Resistant means whatever dose you use, it will not work. Next slide. The break point, they keep diluting. They keep diluting the antibiotic, dilute until it becomes resistant. So the breaking point is a point at which it becomes resistant. Any antibiotic, by continuous dilution, it will become resistant. So next slide, sir. Next slide. No, that slide is not coming. One slide is not projected, that particular slide. So they will tell you that MIC and breaking point. It will tell you the number of dilutions. For example, one antibiotic, you have to dilute 4 times to get breaking point. That antibiotic is better than another antibiotic. Within just 2 dilutions, breaking point will come. The number of dilutions taken to achieve the breaking point is the key factor here. That will tell you whether to choose the antibiotic or not. For example, there can be 4 antibiotics. MIC may be 0.5 for 1. For second antibiotic, it may be 1. Another antibiotic, it may be 2. Another antibiotic, it may be 8. So intuitively, you will think MIC 0.5 is the best antibiotic. Not necessarily. The antibiotic with 8 MIC may require 5 dilutions to get the breaking point. That is the best antibiotic. Okay. So always don't look at the MIC alone. Always look at the breaking point. Can I get that slide there? Is possible?
Yeah, not able to.
Okay.
Okay.
So what are your comments on gliflozin? Last 2 slides. I'm sorry.
So actually, gliflozins are one of the most widely used diabetic drugs in our armamentarium, and obviously they have come into the guidelines with lot of evidence about their cardiorenal benefits. So even if some patients develop UTI, the benefits generally outweigh the risks. But then we have to decide upon looking at the individual patient's risk factors. If you look at the trials published, genital mycotic infections were about 5 to 15% in women, and it's about 2 to 4% in men. But then UTI, the numbers were so small in all the randomized control trials like EMPAREC, CANVAS, and other clinical trials of gliflozins. So obviously the benefits outweigh the risks, but then we have to educate them about before you want to.
Yes, you complete that, please.
Yeah. So obviously before starting the drug, we need to educate them about maintaining the genital hygiene, hydration, and sick day rules when they have to stop. All that need to be educated. And it makes sense to rule out any urinary tract abnormalities, or whether they have got a nephrolithiasis or something which is going to increase their risk to develop UTI. That need to be ruled out before starting the drug. But once they have a documented UTI, say complicated UTI like pyelonephritis or urosepsis, obviously we have to stop, and it might not get restarted again. But you have to balance again, as I said earlier, the benefits versus risk of restarting the drug or re-challenging the patient with this particular drug.
Yeah. Sorry for the delayed. See, if you see this tabular column, quinolones, fluoxetine has the lowest MIC, 0.5. If you see there are 4 sensitive antibiotics, amoxiclav, and you have gentamicin, you have trimethoprim, sulfamethoxazole, of which, see, intuitively you will think 0.5, lowest MIC will work better, right? That's not true, because if you see the sensitivity, 8, 8, 1, 2, 40, if you see the dilution required to get this, amoxiclav has the maximum number of dilution. You need to dilute at least 2 times to get this MIC. But other antibiotic, just with 1 dilution, you get the breaking point. So which is the best antibiotic here? Obviously amoxiclav. So you will look at the sensitivity, you have to compare these 2 columns, sensitivity, MIC and sensitivity. That will give you how many dilutions are needed to reach the breaking point. So this best antibiotic is amoxiclav. So when they show you the culture report, always look at MIC, always look at sensitivity number and try to see the proportionate dilution required. That will give you the best. This is the best way to choose the antibiotic.